All right, everyone. Sorry for and welcome back to the summer course 2023. And now we are going to the last panel from the lecture session. Yay! Okay, tepuk tangan dulu ya. Okay, so and for the last panel, we will talk about the neurovascular. That this panel we have three speakers, one speaker from Universitas Gadjah Mada, one speaker from National Health Research Institute from Taiwan, and one speaker from University of Manchester, UK. And two speakers will join us using Zoom. And to accommodate these sessions, I would like to invite one of our staff from Department of Neurology, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Dr. Vega Pratiwi Putri, M.Sc. Neurologist. For the next around 1.5 hours, I will give the stage to Dr. Vega.
Yeah, good afternoon, everybody. Right, I think it is the last session, right? Yes, I'm Vega, and I'm so honored to be a moderator today in your last sessions, talking about neurovascular disease and stroke. We all know that stroke become one of the most diseases that may causing the high morbidity and morbidity worldwide, especially in developing country Indonesia. Throughout the year, a lot of new technologies, new treatment has been rising in terms of acute stroke treatment, such as thrombolysis and then thrombectomy, so that this treatment is expected to reduce the morbidity after stroke. Because we all know that patients after stroke almost always have a sequel like hemiparetics, cranial nerve palsy, etc. So specific strategic in the acute setting is very important. And as the technologies become more developed, we need to engage more in the personalized medicine, especially precision medicine. We hope that by collaborating our existing treatment management in stroke patients with the precision medicine, so we can give the patients more accurate and more personalized treatment. So joining us today, three outstanding speakers from three different universities. And joining us today is my teacher, Professor Dr. Ismail Setyopranoto, neurologist consultant. Currently, he is a head of neurology department in Faculty of Medicine, Nursing and Public Health, Universitas Gadjah Mada. And today, he will talk a lot about precision medicine and how it challenges in the developing countries such as Indonesia. And for Professor Dr. Ismail, please welcome.
Thank you for all. Good morning or good afternoon today. Okay, good afternoon. Okay, stroke until now there are still a problem. Yeah, not only in the industrial countries, especially in developing countries. Yeah, for us in Indonesia. So one of the problem of stroke, there are is individual of treatment, individual of how to sense, yeah, the patient have of the problem, yeah, because he not know whether there is a stroke attack, yeah. So patient not aware he has still a stroke attack, this problem. So yeah, today I give you one alternative, yeah, to more information. One of the solution is precision medicine. Precision medicine is part of the personalized medicine. Yeah. This issue, there are not opposite with evidence-based medicine. The approach of evidence medicine is population, but precision medicine, the approach of precision medicine is individual. Yeah. The second problem, yeah, patient with stroke, yeah. There are admitted in our wards, neurological wards, yeah. Patient, there are risk factor controllable, yeah, controllable. Have not of risk factors except of hypertension, for example, yeah. Patient have not of diabetes, but yeah, the worsening condition, yeah, we cannot know what of the cause of the worsening, yeah, because many medication give the patient to this patient, but the worsening is continuous until bad outcome. Now there is a big question: why in the patient? Yeah. Okay. Okay. Oh ini. Okay, that is our introduction. Yeah. Neurovascular disease. For example, for the neurovascular disease, the most of the famous of the disease is stroke. Yeah. You as doctor, you should be know about the mechanism. You should be know about the pathophysiology. You should be know about the pathogenesis and pathobiology. The basic of the precision medicine is a pathobiology. So, maybe during 2000 until 2010, yeah, develop of evidence-based medicine for all management of stroke, all of the management of non-communicable disease. Yeah, there are make of many applications. Yeah, according the national consensus, with working group consensus, or maybe international guidelines. Many doctor, many country, yeah, applied this national consensus of international guideline. So, yeah, neurovascular disease with approach with individual, yeah. You as a doctor, you should be about genetic profile by individual of the patient, yeah, proteomic profile, and maybe metabolomic analysis. Yeah, with that approaches, yeah, that means personalized medicine or precision medicine. So the application of that's individual therapy. Nah, the combination between evidence-based medicine and precision medicine make a doctor confident and certainty. Yeah, that is a principle, important principle. Okay. Okay. Definition of precision medicine. Yeah. Precision medicine, according to the National Institute of Health, NIH, yeah, is defined as an approach to the treatment and prevention of disease that takes into account individual variation in genes, yeah, environment, and lifestyle. That different with evidence-based medicine. Evidence-based medicine, yeah, emphasizes in population, not individual. Yeah, population maybe the community, maybe patient in hospital. But precision medicine only individual. Okay, consequences of that. Precision medicine can be a new direction for effort to improve the quality of public health. Yeah, that's, I think, you as a doctor, yeah, for the next doctor, yeah, you should be learn about that. Yeah, okay, lanjut. Okay, that is very, very important. Yeah, personal medicine, yeah, at food drug admission, then and now, yeah, personal medicine accounted for just 5% of the new drug United States Food and Drug Administration approved in 2005. Yeah, in 2019 they accounted for 35%. Yeah, there are, yeah, just only 4 years. Yeah, there are increase from 5%, yeah, until 25%. Okay. Precision medicine takes into account individual genetic differences. Yeah, the traditionally doctor use family history, yeah, socioeconomic circumstance, yeah, environmental factors, risk factor, yeah, family tree, yeah, and maybe contact with someone with infection, yeah, during COVID. Yeah, that is a traditional approach the doctor. But at now, yeah, or maybe in the future medicine, yeah, the doctor, yeah, to explore the patient, yeah, he can do with genomic or genetic testing. Maybe the doctor should be explore the proteomic profiling and maybe metabolic analysis. Yeah, that's context or the future of doctor. That is very important. Yeah. Okay. Next, effectiveness of drug is a factual. Yeah. Is evident. Yeah. But not all of the doctor knows about that. Yeah. Effectiveness of drug, hypertension drug, yeah, especially in ACE inhibitor, yeah, only 10 under 30%. Yeah, effectiveness there. Heart failure with beta blocker, only 85 until 25%. Yeah. Antidepressant, yeah, 20 until 50%. Cholesterol, 30 until 70%, and asthma, 40 until 70%. So that is a very, 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 you should, the doctor should be careful, yeah. Not all of the drug, especially in hypertension, their eye is effective. So what of the cause of the effectiveness of drug? So in the future, yeah, at now, yeah, maybe only one, precision medicine, yeah, because all of the drug with anti-hypertension, yeah, the mechanism all of the drug for hypertension with receptor approaches, yeah, with receptor, yeah. Now that is very important, yeah. At now, yeah, one drugs, one of the diagnosis, especially the hypertension, maybe have not only one receptor that is responsibility to make of hypertension. Yeah, for example, in idiopathic hypertension, there are half of more than 6 receptor that is responsible to hypertension. Yeah. Okay, right. Okay, that is a timeline of advances in understanding and treatment of hypertension. We know that hypertension is risk factor of neurovascular disease. Yeah. From 2060 before Christmas, yeah, until 2010, yeah. There are discovery of genes for monogenic syndrome, yeah, with to develop, yeah, genome-wide association studies, yeah, GWAS, yeah. There are timeline of the hypertension. Okay, for next. Okay, hypertension, there are anti-hypertension drugs. They are full of the dangers of drug because, yeah, about 7%, yeah, in the patient in the hospital experiences serious drug reaction, yeah. I think this is very, very high, yeah. The complication, yeah, with drug, especially for hypertension, not only, yeah, the case of blood pressure, but it's very, very dangerous. There are is the body, especially endothel, cannot to prevent, yeah, endothelial damage, yeah, because, yeah, one of effect antihypertension drug, yeah, there are is individualized problem, yeah, not all the patient, yeah, okay, okay. The old paradigm, yeah, there are a disease severity and there are a time, yeah. The old paradigm, yeah, patient, a doctor make a diagnosis, yeah, with the patient, yeah. The doctor, yeah, selects on the drug, yeah. What the drug is maybe piece of economical, piece maybe yeah simple, yeah, maybe accessible, yeah. After that, switch a drug, yeah, and then switch drug again, yeah. Okay, that is still problem in Indonesia, yeah. Okay, new paradigm, efficient medical care, yeah. The doctor, yeah, make of the predisposition with a screening, yeah. The doctor construct a diagnosis, yeah, and prognosis, and the doctor choice both of the right drugs. Yeah, after give the patient with this drug, yeah, the doctor should be monitoring, yeah, by the follow-up, yeah, because there is hypertension, for example, or stroke, so long life follow-up for the patient. Yeah, okay. The last, yeah, future paradigm, yeah, a preventive medical care, yeah. The doctor make a predisposition and screening the patient, yeah. By the doctor make of the prevention measure, and after that monitoring the patient, yeah, forever, yeah. Okay, it's very not expensive, yeah, maybe very cheap, very simple, yeah. But what of the expensive for to make that choice? Technology, yeah, genomic technology, pharmacogenomic technology is very, very expensive. That until now, there's a problem in the developing countries, yeah, such as Indonesia. Okay. Okay, precious medicine today, yeah. That is Jessica Ken. Genetic variant associated with hypertension and risk factor of a stroke, yeah. That is 2000, yeah, 23, yeah. So very, very recent, yeah. Okay, basic strategies for precision medicine in neurovascular disease, yeah. The approaches for that, population level genetic screening, yeah. After that, identification of susceptible individual, yeah. And then the last, yeah, personalized recommendation for prevention, yeah. This schema is very, very simple. Yeah. Okay. Last. Yeah. For the next, the plan. Yeah. Newborn screening expand to track hundreds or thousands of genes. Yeah, rather than dozens. Yeah, information is used throughout the individual life to manage their health care. I think there are not dream, yeah, not dream, yeah, but on the facts, yeah, in many in Indonesia, in Sarjito, yeah, there are instead of identification of genomic, yeah, for the newborn, yeah. I think for next, yeah, the patient can do identification for next, maybe for the cancer, non-communicable disease, for example, hypertension, diabetes, yeah. That is in Indonesia, yeah. For the next, I think can do a new paradigm of medication, yeah. Okay. Blood and other samples drawn during routine medical visit are submitted for molecular screening for a large number of cardiovascular, cancer, neurological, and other diseases that may develop. Nah, yeah. Okay, on the plan for the next, medical information on smart card, yeah, contain our unique molecular profile. Healthcare providers will consult the profile before treatment drugs are prescribed. Yeah. Or yeah, maybe with smart card, yeah, for the patient, for all the patient, yeah. That is to simple the procedure of clinical activity, yeah. You as a doctor, yeah, with a simple process. Okay. Gene sequencing examination, yeah. For example, yeah, restriction fragment length polymorphism, yeah, analysis, or maybe single nucleotide polymorphism, yeah. There, this is one of the for the example, yeah, for hypertension. We know that hypertension is one of the risk factor, yeah. The higher risk factor of stroke, hypertension, combined with diabetic. Yeah. Okay. Yeah. There are for example, yeah, the sequencing of gene, yeah, make a microarray, yeah, to identify cell of the proteome, yeah, yeah, with the protein, and there are is the identification of metabolome, yeah. Okay. 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 For the direct, I think. Okay. Okay, what the test do disagree on, however, is the disease risk. Yeah. Do predicted disease risk have any clinical validity? Yeah. Genotype-phenotype correlation? Yeah. Certain disease risk can be better predicted than others. Yeah. Okay. Pharmacogenomic. Does one size reality fit all? Yeah. Pharmacogenetic, study of genetic variation that gives rise to different responses to drugs. Yeah. It is estimated that genetic can account, yeah, for 20 to 95% of variability in drug disposition, yeah, and the effect. Yeah. Non-genetic factors include age, yeah, organ function, concomitant therapy, drug interaction, and the nature of the disease. Yeah, maybe a family, because hypertension, diabetic is the family, yeah, disease. Yeah, or maybe a congenital, for example, many diseases in the cardiac. Yeah, for example, ISD, yeah, or PDA, or PFO, patent foramen ovale. Yeah. Okay. Okay, pharmacogenomic under the precision medicine umbrella. Yeah, better medication choices. Yeah, 10,000 Americans die annually and 2 million are hospitalized due to adverse reaction to medication. Predicts individual reaction to drugs. Yeah, safer dosing option, more exact dosing, optimum result, set effect balance. Yeah, and improvement in drug development. Exclude genetic variation from certain clinical trial, spending up drugs design time. Yeah. Okay. Precision medicine, today or yesterday. Yeah. Maybe that today is recent. Yeah. But for the next, there are is yesterday. Yeah. For example, yeah, cytochrome before 50 genotyping test. There are enzyme group of cytochrome. Yeah. Many types of medication, including antidepressant, anticoagulant, proton pump inhibitor, and etc. Determine dosing and effect of this drug. Yeah. There are many types of cytochrome. Yeah, many types. Many discovery of drug, yeah, target for that. Yeah. For example, for stroke. Yeah. Today, yeah, the doctor for the stroke acute, ischemic acute, the drug is, for example, clopidogrel. Yeah, clopidogrel. At now, there are discovery of the order of cytochrome type. Yeah, for example, ticagrelol, pasugrel. There are a new drug. Yeah, maybe for next, maybe there are no new drug. Yeah, for the old drugs. Yeah, but at now there are new drugs. Okay, tiopurin methyl transferase test. Yeah, tiopurin TPMT. Yeah, for an example. Yeah, there are is many of the precision medicine approach. Yeah, there are today, maybe for the next yesterday. Yeah. Okay, we to example schematic of the precision medicine approach to hypertension. Yeah, many risk factor, many mechanism. Yeah, that is responsibility make the patient have of make of hypertension. Yeah, for that at now with the approaches of precision medicine, bioinformatic, pharmacokinetic select delivery method, and antihypertensive and molecular diagnostic. Yeah. So for all mechanism, yeah, there are can to identify, yeah, of the deviation, yeah, during physiological in the renal, maybe cardiac, or maybe include of the neuronal, yeah, cause of stroke. Yeah. Okay, that is okay. Precision medicine in base consensus clustering of multidimensional data and mechanism-based therapy. Yeah. In the population, there are neurovascular disease cohort to identify many diseases. For example, stroke with many of risk sector. For example, diabetes, dyslipidemia, hypertension. Yeah. There are collect of multi-dimensional data. Yeah. There are to select with many variable clinical data, genome, transcriptome, yeah, proteome, yeah, metabolome, yeah, and then one by one, yeah, make of clustering, yeah, thrombotic, yeah, complement, yeah, maybe there are is still experimental study, yeah. So the consequences of that, yeah, develop of drug A, drug B, or drug C. Yeah. For all, that is a mechanism-based therapy. For all, based on the disease cohort in deaths with use of genome for that, yeah, make of individual therapy. Okay, yeah. For the next, yeah, the medicine, genomic, yeah, in support of the function genomic, informatic, yeah. There are of enabling technology. There are for the next, yeah, biomedical informatics in support of genomic-based medicine. Okay, for the last, yeah, the challenge for precision medicine. Precision medicine, as with every new initiative, has to face a lot of challenges. Yeah, the large amount of data required to be collected, analyzed, is not only an economic burden but also labor and technical know-how, yeah, intensive. Yeah, the anonymization, yeah, of data and its security is a big issue. So, yeah, the ethical challenges are paramount. Noise in the data is another distraction. Yeah, turnaround time for data analysis is at the earliest 26 hours, which is still slow for decision in acute care setting. The validity of such data is also difficult to calculate. The capacity building needs to be done at breakneck speed, especially with respect to training of healthcare workers, yeah, and availability of high quality artificial intelligence, machine learning, and laboratory equipment. In short, for precision-based treatment, population health may be undermined. Okay, I think not only the end, but R is just the beginning. Yeah, thank you for all. Yeah, and good afternoon. Yeah.
Thank you, Professor Ismail. You may sit here. So he is the first speakers of today's panels in the last panel. So we are going to have discussions with the second speakers. Dr. Wen-Hai Chou will attend online through Zoom meetings. So I will introduce him. The second speaker is Dr. Wen-Hai Chou. He is an associate investigator, Center for Neuropsychiatric Research, National Health Research Institute, Miaoli County, Taiwan. He is now will be talking about biomarker-guided therapy stroke. To Dr. Wen-Hai Chou, time is yours.
Good afternoon, everybody. And my name is Wen-Hai Chou. And can you see my video?
Yes, we can see it clearly.
Okay. So the title of my talk is Biomarker-guided therapy for stroke. And I'm working at Center for Neuropsychiatric Research, National Health Research Institute in Taiwan. And as you know, and the previous speaker have told us, the stroke is one of the leading causes of long-term disability and mortality worldwide. And for each person, the lifetime risk for stroke in adults over the age of 25 is approximately 25%. And there are two major types of strokes. The first one is the vessel clot weaving. It's called ischemic stroke and represent 87% of all stroke. And the second one is the vessel rupture causing blood to leak into the brain. It's called hemorrhagic stroke and represents 13% of all stroke. And the major challenging in developing effective new therapy for stroke is the heterogeneity of stroke, including etiology.
Excuse me, doctor. Excuse me
Yes.
for interrupting. You haven't shared the screen through the Zoom meeting, so we cannot see clearly the slides.
Oh, you cannot see the slide?
I can see your video, but I cannot see the slides. Have you shared the screen for your PPT?
You can stop the video, and then I can share my. Can you see it now?
Not yet.
Yes, now. We see it now, thank you.
Okay, sorry about that. Okay. So, so the major challenging in developing effective new therapy is heterogeneity of stroke, including etiology, comorbidity, lifestyle factor that uniquely affect each stroke patient. So, start your new video. Okay, so can you see my slide?
Yes, we can see your slides and your video. Thank you.
So we need biomarker-guided therapy for stroke, and then we need precision medicine for stroke. So ischemic stroke is caused by the blockage of blood vessel in our brain. When the blockage lasts for several minutes, neuron and other cellular elements start to die. And this condition is called infarction, and the area damage is called infarct. And blood pumping from the heart going through internal carotid artery and then divided into three branches: anterior cerebral artery, and the middle cerebral artery, and posterior cerebral artery, to provide the blood supply for the brain. And we often say time is money, and but when we face stroke treatment, time is brain. And every minute, 1.9 million neurons die during a stroke. So the shorter time to treatment, the better. And there are currently 2 reperfusion therapies for acute ischemic stroke, which are approved by FDA. And the first one is to IV inject recombinant tissue plasminogen activator, RTPA, and which was approved by FDA in 1995. And if we need to perform this injection within 4.5 hours after the occurrence of stroke, and if performed later, and there is a chance of developing hemorrhagic transformation, which is bleeding in the brain. And the second one is approved 20 years later after 1995, which is approved by FDA in 2015, endovascular thrombectomy. And it can be performed 24 hours after stroke. But if later, it will develop hemorrhagic transformation. So if a patient arrive in hospital in time, still there's vascular challenges for reperfusion therapy. So the best outcome is the reperfusion of blood, like shown in the panel B. And there are several pitfalls, like no recanalization, or recanalization but no reperfusion, or the worst scenario is the hemorrhagic transformation and bleeding in the brain. And so on the left is before the treatment, and on the right is after the RTPA. You can see the blood is reestablished. And however, the reperfusion after RTPA, and we also face a possible secret killer, is called stroke reperfusion injury. So reperfusion injury induced after RTPA and EVT treatment is a major contributor to hemorrhagic transformation. And free radicals, excitatory amino acid, and pro-inflammatory cytokines, and especially neutrophil, will contribute to the reperfusion injury. And here is a neutrophil in the blood vessel. And at the resting stage, they are circulating in the blood vessel. And in response to stroke reperfusion injury, it will slow down its rolling and adhere to the nearby blood vessel and transmigrate to be near to the target. And they will produce superoxide ion and protease through degranulation and further damage the penumbra area. So one molecule that I think might be useful for biomarker-guided therapy and maybe used for precision medicine in stroke is called neutrophil gelatinase associated lipocating NGAL. And it's also called lipocating 2 LCN2, and because of its size, it's also called 24P3. And it's a small molecule, 25 kilodalton, synthesized and stored in specific granule of neutrophil and secreted in response to injury. And the panel here shows the immunoelectro micrograph of human neutrophil that is stored in the human neutrophil. So what is the function of NGAL? And it's iron therapy. It has antibacterial effect by stealing iron from bacteria. So we can see from the crystal structure of NGAL, and the iron in orange color is captured inside the NGAL. It itself cannot bind iron directly, but it has to bind through siderophore. And siderophore is iron chelator with really high affinity. It's a KD of 0.41 nanometer. And so when bacteria invade our body, they think iron is precious. They will take the iron away from us. And so we human will produce NGAL and will steal the iron back. So this is one of the function of NGAL is iron silvery. So the receptor of NGAL has also been reported. It's called BOCT. It's brain type organic cation transporter. And it can induce, the NGAL can induce apoptosis by reducing intracellular iron concentration. So when NGAL is internalized by BOCT, and it will reduce the intracellular iron concentration and induce Sp.N, and will stimulate apoptosis. So here is in a panel A is a transcript of BOCT. Is everywhere. It's ubiquitously expressed in cortex, hippocampus, and striatum. In the panel B is a Western blot showing that the BOCT is expressed in cortical neuron, but not in neutrophil, but it's in the brain tissue. And panel C show the immunocytochemistry, showing that BOCT is expressed in MAP2 positive neuron. So on the other hand, NGAL itself, under non-ischemic condition, is undetectable in neuron, but enriched in neutrophil. And in the panel A is a transcript of the NGAL is absent in the brain tissue from the Allen Brain Atlas. And on panel B, the NGAL is enriched in neutrophil, but absent in cortical neuron and the brain tissue. So then we use a mouse model to model ischemic stroke. So on the left-hand side here, we put a mouse here, and we first use a laser Doppler probe attached to the head, and then we will measure the baseline of the blood flow. Then we will flip the mouse over, and we'll find external carotid artery, ECA, and we'll put a suture into the ECA, then through ICA, and reach the origin of middle cerebral artery. And the reason that we accrue the middle cerebral artery is because this artery is the artery that 80% of human stroke happen in the middle cerebral artery. And after 1 hour occlusion, and we will withdraw the suture and allow the reperfusion of blood, and will allow the reperfusion injury kick in. And on the here you will see that we will generate infarct in the right hemisphere. And we can also slice the brain, and we can see that the use the TTC stain, see the infarct area and measure the infarct differences when we give different kind of drug. And here is under non-ischemic condition, the NGAL in green color, and we use the lectin to label the blood vessel and use the GFAP to label the astrocyte. And you can see the end fit of the astrocyte is encircle the blood vessel. Under non-ischemic condition, there is no NGAL. And after ischemia, here's the infarcted area, and here is a penetrating artery. And you can see that the NGAL start to appear in the as a thin layer in the blood vessel, and also it appear in the neutrophil. So here is a larger picture showing that NGAL appear as a thin layer, and the red is the blood vessel, and the outside is another layer, is the end fit of the astrocyte. So we also see in the penumbra area, here's the infarct area, here's the penumbra area, that the NGAL in green color is induced in the GFAP astrocyte. So here's the blood vessel, and here is the GFAP positive astrocyte that is encircle the blood vessel, and you can see the end fit here, and you see also the green color NGAL is induced in this GFAP positive astrocyte in the penumbra area after stroke. So we want to know the function of NGAL because it's NGAL induced after stroke. So we use the monoclonal antibody, and we first do in vitro experiment that NGAL monoclonal with increased concentration 0.5 to 0.5 and can immunoprecipitate more NGAL in the solution. Here is the amount in the supernatant. So this is the amount that we put, and this is the amount that we immunoprecipitated. So then we use this monoclonal antibody and inject it into the mice after stroke, and we can see that it improves the neurological score. And also we use a corner test. We found that the number of right turn is reduced. And also you can see the TTC staining. On the left-hand side is the control IgG, and right-hand side is the after the NGAL monoclonal antibody treatment, the infarct area is reduced. And here's the total infarct volume is reduced, and also it reduced the brain swelling after NGAL monoclonal antibody treatment. So we also use Evans blue and to see the blood-brain barrier leakage. You can see that the control IgG did not stop the blood-brain barrier leakage, and you can see the bluish here. And after the treatment is reduced, and here is quantitative data showing that NGAL monoclonal antibody reduce the leakage. And Claudin 5 is a component of blood-brain barrier, and you can also see that the NGAL preserves the integrity of blood-brain barrier. And MPO is a marker for neutrophil. So you can see that after treatment, the invasion of neutrophil is reduced. So we also use qPCR and found that there are several pro-inflammatory chemokine cytokines is induced after stroke, such as INAS, IL-6, CCL2, and CCL9. It is induced after stroke in the wild-type mice. And here is our knockout mice. And here is after the treatment. So it's reduced after NGAL monoclonal antibody. So in summary, that we found that after stroke, the NGAL is induced as a thin layer in the blood vessel, and also induced in astrocyte attached to the blood vessel, and also carried by NGAL, carried by neutrophil. NGAL also carried by a neutrophil. And that it will be released in the penumbra area, and that will amplify post-stroke neuroinflammation in an autogreen and paragreen manner. And when we neutralize NGAL using the monoclonal antibody and neutralize NGAL axis, diminish neutrophil invasion and protect from ischemic stroke. So we have seen that NGAL induce in the brain tissue after stroke. We also observe that NGAL is induced in the blood serum that appear 1 hour after stroke and increase further and peak at 16 hours after stroke. And its binding partner MMP9 appear earlier, peak at 4 hours after stroke. So NGAL and MMP9 form a complex together. So we also found out that NGAL and MMP9 expression in infiltrating immune cell after stroke. So here NGAL in green color, here is a blood vessel. There are several immune cell infiltrating into brain tissue, and it has the expression of NGAL as well as the expression of MMP9. So our hypothesis that MMP9 has been implicated in deterioration of blood-brain barrier, worsening of cerebral infarction, and functional outcome after RTBA treatment in human, and this we know. So previous study indicates that NGAL form disulfide-linked heterodimer with MMP9, and the interaction stabilize the gelatin-lytic activity of MMP9. So the hypothesis is the level of MMP9, NGAL, and their complex correlate with the occurrence of brain edema and hemorrhagic transformation. So here is the MMP9 about 92 kilodalton protein, and here is its complex, and because NGAL is about 25 kilodalton, together is about 110 kilodalton. So our study design is that after stroke, that we collaborate with neurologists, they will score the NIH stroke scale at admission, and they will collect the blood from artery and the vein before the RTBA treatment or before the EVT treatment, and they perform the injection of RTBA or the EVT. And then after the treatment, they will collect the blood again. And at 24 hours, they will use the CT to confirm whether the patient has the hemorrhagic transformation or edema. And 3 months later, they also will confirm their severity. So far, we had enrolled 77 patients, and with the age of 68 and 43 male and 34 female. And because the hospital that we collaborate with is a big hospital, so most of the patients that was enrolled there is through EVT, because EVT needs to have radiologists, neurosurgeon, and also neurologists. So there are more EVT patients, and this is their stroke scale. And unfortunately, that there are 28 hemorrhagic transformation patients and 13 edema patients. So currently, we are analyzing the level of MP9, NGAL, and their complex by ELISA, and we will assess the predictive value of this biomarker in identifying brain edema and hemorrhagic transformation. So in summary, we found that NGAL is undetectable in non-ischemia brain tissue and induced after stroke in cerebral endothelium cell and astrocyte, gating the blood-brain barrier. And we think NGAL amplified post-stroke neural information in an autocrine and paracrine manner. And neutralization of NGAL by the NGAL monoclonal antibody diminish neutral invasion, protect from ischemic stroke. And NGAL is a potential therapeutic tactic to treat stroke reperfusion injury. And also NGAL is released in blood plasma, possibly by neutrophil. And NGAL bind with MMP9 to stabilize its activity. So the NGAL, MMP9, and their complex are potential biomarker to be included in biomarker-guided therapy for stroke, and also can be used for precision medicine for neurovascular diseases. And thank you for your attention.
Yeah, thank you for Dr. Wen-Hai for the presentation. It's very interesting. So we are waiting for the questions from the attendants today, talking about the lecture that you have given. this time. So moving to the third speaker of today's panel's discussions, the third speaker is Professor Delvac Oceandy. He is a professor of molecular cardiovascular science, Division of Cardiovascular Science, the University of Manchester, United Kingdom. He is currently joining us through Zoom meetings. So please welcome Professor Delvac Oceandy.
Yep. Good morning. Oh, sorry. Good afternoon, I should say. Can you hear my voice?
Yes, Prof. I can hear your voice
That's okay.
clearly.
All right. Okay. Okay. Thank you very much for inviting me and for having me in this conference. I would like to share my screen. Let me see. Okay. So my name is Delvac Oceandy. So it's already been mentioned. I'm currently based in University of Manchester in the Division of Cardiovascular Science. So what I would like to talk today is to introduce a little bit from research from my laboratory regarding, and I just put a focus in nucleic acid therapeutics, which is, I think, one of the main things for the future development of precision medicine approach. So let me change to laser. Okay. Right. So the nucleotide-based therapy, or also called gene therapy, have different strategy and have changed in the strategy recently. So normally what we know regarding DNA or RNA therapy or gene therapy previously is used mainly to correct mutations and mainly directed to treat some genetic hereditary disease, mostly less common diseases like cystic fibrosis, Leber's neuropathy, and so on. So there is a mutation in the patients and we want to correct the mutation. But now it's developing. So some of new approaches in nucleotide-based therapy now are directed towards compensating for the function loss. For example, if in some disease, like in cancer, we can detect the major player in the development of the cancer. For example, if in cancer there is a loss of p53 tumor suppressor genes, then we can compensate the loss of this function by sending the genes so that it will correct the pathophysiological or the molecular process that driven the disease. But now it's developed again that gene therapy can be used to modify the function, the molecular function specific signaling pathway that involved in the development of disease. And this is really exciting because this can be used to modify the phenotype outside the genetic changes itself. For example, in some more common diseases, for example, in the heart failure or hyperlipidemia, we can target some pathophysiological process. For example, the calcium signaling, we can induce a molecule that can improve the phenotype, the contractile phenotype of the heart cells using molecules like SERCA. Or we can reduce the development of hyperlipidemia by targeting genes that important in the process. So it's not always to correct the mutation or to target the gene that defective, but now we can use the nucleotide therapy to improve or to modify signaling pathway. So then this is really exciting. So what I would like to discuss in the next few minutes, maybe 15 to 20 minutes, is just to give some introduction about gene therapy, nucleotide-based therapy, and then give you some examples of what we've done in our lab in Manchester. So the first one, this is a continuation from the previous slide. For correction mutation, normally people use CRISPR. So this is a new method to cut and paste and modify the DNA sequence. For compensation for function loss, we can put the whole genes coding region. I mean, the majority of the strategy for this one is using DNA. But for alteration of function, the majority is using RNA. And this is what I'm going to focus. So RNA therapeutics using several different RNA to alter cellular function using some genetic tools. So one other important consideration is the delivery of the nucleotides. There are two options using the viral delivery and non-viral delivery. Normally, when we use DNA, we need a virus. So it can be adenovirus, lentivirus, adeno-associated virus. And this will induce a long-term local delivery is possible, but also cell-specific delivery if we can use a specific promoter to direct the expression of the particular gene. But for RNA therapy, we cannot use virus, but we normally use a nanoparticle or direct delivery in the organ or specific site that we want to target. Okay, so why RNA? So this is some very general background. We know that RNA is part of the three major components of the basic modern biology. So DNA encodes the protein, and before that, it needs to be transcribed to RNA. But if we understand now, the RNA is not only the coding RNA, but we got a lot more other types of RNA, one of which is RNA interference, RNAi. So basically, this is two opposing factors, the coding or messenger RNA responsible to express protein, but the non-coding or the RNAi, it's the opposite. It's inhibiting the production of protein through RNA translation. So there are two different types of RNA interference. siRNA is the one that's normally or naturally found in prokaryote, in bacteria and so on. It's single strand and it targets single genes. But in eukaryotes, including in human, it's the natural expressed non-coding RNA interference is microRNA. The difference is that microRNA targets multiple genes, and the mechanism is slightly different, can be through several different approaches like repression of translation or degradation of the RNA. But now this is the most important general principle in the RNA therapeutic, is that we have two types of RNA that we can use. The messenger RNA, that's to induce expression, and the RNA interference to reduce or to stop the expressions. That means we have both tools to gain the function of specific protein or to inhibit. So we have something to accelerate and as a brake to inhibit. which is really important because the concept of modulating signaling pathway or the cellular process for therapeutic purpose can be dramatically changed in the future because of the development of these technologies. This is the example. So normally the function of a cell is like this. So cell responds to the ligand, like hormone or cytokine or something. Ligand binds to receptors, and this will induce signaling pathway, and the cell responded. To modify the function for therapeutic approach, previously or until now, mostly done by pharmacological compounds that target the ligand binding to receptor, blocking that, or inhibit the signaling pathway, and mainly through the inhibition of enzymes or like kinase, protease, ATPase, or something like that. But it is really important to note that pharmacological inhibition using the pharmacological compounds is not, there's a lot of limitation because it's difficult to target molecules that do not have the enzymatic capacity or not the receptor ligand binding responsible for that. So something like transcription factors, structural protein is really difficult to target using pharmacological compounds. And there is an issue of non-specificity. But by using the nucleotide approach, as long as we have characterized that, we basically can target whatever protein we want, and we have the tools of inhibiting and gaining the function using RNA messenger or RNA interference. So that's the basic principle. So in this case, for the future of the therapy, as long as we can identify in a particular patients or something, what kind of pathway or function that abnormal, then we can target that. So we can design a specific or personal precision approach for a specific patients. Right, so that's the first part of my talk, and then I'm going to give some example about how we use the RNA technology in a basic cardiovascular. So it's not the clinical study. So my lab is a preclinical or molecular biology laboratory. So we use this to address the main or the big question in the field of cardiovascular area. So the main question is that people after a heart attack, myocardial infarction, there is a big chance that they will develop a heart failure despite the high survival rate following revascularization and so on. So that's the reason is that following myocardial infarction, if people survive the acute part of the disease, then there are a lot of cardiomyocytes that died, and that's because the adult cardiomyocytes have very limited regenerative capacity. So this is the problem after myocardial infarction or heart attack, massive cardiomyocytes death. And then we think that if we can inhibit this process leading to heart failure, so because of the loss of the majority of cardiomyocytes, the heart will remodel and it will develop heart failure. So if we can inhibit the process by inducing cardiomyocyte regeneration or increasing the pro-survival pathway, so we hope that we can reduce the process from damaged heart to heart failure and so on, from myocardial infarction to heart failure. So the question is how to induce this process. So there are several examples in my lab. So first one is we have identified the signaling that normally is not active in the adult cardiomyocytes, and we would like to reactivate that to induce cardiomyocytes proliferation. And one student in my laboratory, Ryan Potter, have identified serotonin receptor 2B, 5-HT2B, that can modify the hyposignaling pathway. This is the signaling pathway that's important in heart or cardiomyocyte regeneration. The problem is that the pathway is locked in the adult cardiomyocyte. So adult cardiomyocyte not able to regenerate. But this is active in the developmental or in the embryonic heart development. So we would like to open the key or unlock this by using 5-HT2B, and this is happen in the cardiomyocytes culture. So when Ryan introduced this receptor and activated, the cardiomyocytes began to proliferate. So this is some marker of cardiomyocytes proliferation. You can see the increase in the proliferation by about 2-fold. And then the tunnel is the marker of apoptosis. You can see that the survival rate in response to peroxides or oxidative stress is reduced significantly. So we think that if we can induce this in mouse in vivo, we move from cell to mouse experiment, then this will improve the phenotype following myocardial infarction. So we've got the the transgenic mice from our collaborators in France, and the mouse have a consistent phenotype to what we think before. So if we overexpress 5-HT2B, the heart is bigger and have a lot more cardiomyocytes. But if you knock out, the heart is smaller because of less cardiomyocytes, so because of less proliferation. But this is a genetic knockout and overexpression. That means the gene is knocked out or overexpressed from the embryonic heart. So then we try to get the mouse and then do the myocardial infarction with the hope that if you overexpress this protein, serotonin receptor in the heart, then it will protect the heart from pathological changes following MI. But this is the result. We got completely the opposite. So the red one is the transgenic after MI or myocardial infarction, and the blue one is wild type or normal mice after MI. And you can see there is a lot of transgenic mice with this regenerative factor died within the first 5 days following MI. So this is something opposite to what we expected. So then at the end of the experiment, we didn't see any difference in the phenotype of the heart. LVBW is the heart size, left ventricular weight normalized to body weight. Ejection fraction is the cardiac contractility, and the scar size is the area that infarcted in the mouse model. So all the same. So what happened in the first 5 days? We then try to look at the second day of MI. Then we saw something really interesting, that in the transgenic mice that's supposed to be protected, we've got the hypertrophic heart. So heart weight, body weight really increased after only 2 days following MI compared to the wild type. And that makes the cardiac injury bigger because this is the troponin I ELISA is also significantly higher. So we think that inducing regenerative factor or proliferative factors from the embryonic states will not be beneficial because the hypertrophy is already achieved before the disease. So then we think that's probably using the genetic approach or not the transgenic. So introducing the factors in the middle of the disease probably is more beneficial. So we have 2 choices. Using the RNA approach, modified RNA, this will have expression transiently increase after a couple of days and then going down in 1 week, or using the virus. Both got plus minus. And then we think that's probably because the problem is in the first week, we have to modify the pathway only in the acute phase of the disease. That's it, the 1 week. Because if we introduce it longer, persistently, then we are afraid that it will causing some unwanted or side effects in the long term. So we try to learn how to use the messenger RNA approach to do the gene therapy. So we use the modified RNA. This is the component of the modified nucleotide containing UTR coding region and so on. Basically, we just try to put it together, optimize its sequence, and then do the nucleotide modification. This is based on the paper by Kathleen Carrico and Drew Wiseman, that we need to modify the messenger RNA, because if not, then this will induce inflammatory response and the RNA will be damaged. So as you know, these two papers lead to the Nobel Prize winner this year, and this is the basis of the RNA vaccine that's successfully developed during the pandemic. So we use similar approach, excuse me, and we successfully developed the RNA to induce the serotonin receptors. This is just the optimization in mice. You can see the expression of the control gene luciferase and the serotonin receptor following direct injection of the RNA into the heart. So we open the chest and then induce the RNA. And then we did this similar experiment in the myocardial infarction, and the result is completely the opposite of the transgenic embryonic overexpression, so that we got better survival rate in male animals following modified RNA expression of STR2B. And then when we look at the cardiac phenotype, there's a slight improvement, although it's not statistically significant in terms of the infarct size and also the development of scar tissue, the infarct area, and so on. So we still working on that to find out what is the mechanism why there's some degree of improvement, but not reaching some significance, because probably there is some effect on fibroblasts and so on. Right, so that's the first story on the serotonin receptor. So that's the story of inducing or increasing protein expression using RNA. The second experiments coming from experiment using the other way around. We use the RNA approach to block the expression of some factors that may induce development of cardiac remodeling and so on. So this is based on experiments that done many years ago by one of my postdocs to identify microRNA that can induce or modulate the developmental genes in the heart. So to cut long story short, we've identified microRNA 411, and one of my students, Bayu Nugroho, who is from UGM, now he's postdoc in my lab, focus on this microRNA and re-express that. And then he found some interesting results that this is cardiomyocytes. So once he introduced microRNA 411, as before, the proliferation increased significantly by about 2-fold. So this is really promising. And then he did similar things to move it to the in vivo testing in the animal model, and he developed some methods to introduce the microRNA, and the best nanoparticle that we found to introduce the microRNA is polyethylenimine, or PEI, and this is the evidence showing the expression of the miRNA following injection and the induction of mitosis in cardiac myocytes in the injection sites. So it's very local and it's transient. So what he did after that is, as before, we induce myocardial infarction in mice and then introduce the microRNA 411. And this one is more or cleaner results than the 5-HT2B. As you can see here, the remodeling, the heart width, tibial length is improved. The ejection fractions also improve, so you can compare between this and this probably. And then the scar size is also reduced significantly. And when he tried to look at the mechanism, he found that the apoptosis is reduced and the cell cardiomyocytes start to enter the mitosis phase during the acute phase of myocardial infarction. So this already published, so you can look at this paper if you want to look at the finding in more detail. And then lastly, I hope I still have some time because this is slightly different. So the examples, the two previous examples, we want to target developmental pathway in adult heart by using messenger RNA and microRNA. But we want to know whether we can also target other signaling pathways. So what we did in this experiment is to try to target autophagy. So autophagy is really important during cardiac remodeling following MI, because following heart attack, there's a lot of accumulation of damage, toxic materials, organelles, and so on. Autophagy is important to remove that, to clean everything. So if you can induce autophagy, then hopefully we can help the heart to remove all the toxic molecules, and this will improve the phenotype following heart attack. So we target the process. This is the process of autophagy. I think I don't have time to go through that. Anyway, we found one molecule, complex of microtubule associated protein called MAP1S that we think can improve the autophagic flux, the autophagy process in the cardiomyocytes. And one of my students already got some evidence, again, in vitro in the cells. This is heart cells, and these dots, red and green or yellow here, is from the marker of autophagy. And you can see that overexpression of these molecules, this is the quantification of the dots, increase the number of autophagic vacuoles in the cardiomyocytes, meaning that the autophagic flux is faster and increased. So we use that model, and we did the same thing using messenger RNA injecting in the heart, and they successfully induced the expression of MAP1S. And the result is, again, is very interesting. That number one here, you can focus on the graph in the middle, that after myocardial infarction, and then we induce the autophagy using the nucleotide RNA-based approach, then this improve the ejection fraction, the function of the heart, and fractional shortening, and reduce the apoptosis. This is tunnel, the apoptosis is reduced, and reduce the infarct size, meaning there's a lot more cells survive following MI. So this is also quite promising result from one of my PhD students, and the study is still ongoing to find out the precise mechanism. So that's probably the three examples from the lab, and my final slide here is the summary that the RNA therapeutics, I think, have a very, very great potential for the future, because we can, using this approach, we can target virtually all types of regulatory molecules to modify cell function. So this is very, very powerful tools in terms of precision medicine, because in the precision medicine approach, we want to target precisely what's going wrong in one patient. And once we know that, we can use the nucleotide-based approach, and we have the tools to induce the function of the target or inhibit the function of the target, whatever we want, we can do that. And then there is a flexibility in the delivery of the DNA or RNA materials using nanoparticle, and that can be done systemically or organ-specific directly to the organ. But of course, there is still a problem, there is a challenge regarding, we know that it's not cell-specific. So what any cells, for example, in the heart, we got cardiomyocytes, fibroblasts, immune cell, and so on. Everything will be targeted. So that's probably the reason why in the first example, the first experiment, the serotonin receptor, we didn't see significant improvement because it probably goes to fibroblasts and cardiomyocytes at the same time. Okay, so I will stop here. And lastly, I would like to thank members of the lab. So it's people in the lab that responsible in generating all the data that I just presented, and all the funder, British Heart Foundation, Medical Research Council, and Heart Research UK, with supporting our research. Thank you very much for the attention, and I'm happy to take some questions.
Thank you, Prof. Delvac, for the great presentations. Give applause to Prof. Delvac. Yes, so we are jumping to the question and answer sessions. Is there any questions from the attendants? Yes, please.
Check. Okay, I'm Brian. I'm representing University of Gadjah, Mada. I would like to ask to Prof. Ismail, but if the other speakers would like to give comment on this, is fine. So talking in Indonesia, there are tons of people who are not willing to do the health screening. In the past, they thought that it's expensive, but even if right now we already have BPJS or National Health Insurance, the understanding from the society is like if they feel that their body is okay, they don't want to go to the health screening, even though they are like maybe at high risk. For instance, like they're obese or they have a diabetes. So linking about our discussions about precision medicines, will the screening program of the precision medicines will be feasible to be done, knowing that A, it's still new and expensive, and also it takes a long time as well. Other than that, we are afraid that this new idea will be exclusive for those who are wealthy or in a stable economic condition. But in fact, those who are really need this is the marginalized community or who are less educated and negligent about their health. And my second question is also, what about the medicine? Notice that everything will be based on individual. So will the pharmacy company only make the medicine for those who can afford that? That's all from me. Thank you.
So you got two questions. The first is about the reality that we actually have a difficulty in doing screening in Indonesian populations, due to the lack of insurance and education, etc. And the second question is about, because it is the personalized, how about the pharmacy industry? Will they make drugs that actually suitable for only 1%? Okay, so please, Prof. Ismail.
Okay.
Thank you.
I think that is a common question and common problem. Yeah. We know in Indonesian population there are many of basic identified of personal. Yeah. Based on race, yeah, based on geographic, yeah, based on climate maybe, yeah. So it's mean the mobility of Indonesian people, yeah, at now and maybe for long ago, yeah, it's very different. So it's mean make of the specific gene in Indonesia. For example, yeah, you know about Minangkabau, yeah. What about the daily food in Minangkabau people, yeah, rendang, yeah, rich of coconut, yeah, less of the fibers, sayur apa, vegetable, yeah. You should be compared with Sunda, yeah. There is a rich of fish, rich of vegetable, and so on. So my question, there is a different of genotype, yeah, to respond of the cellular exposure of hypertension? Yes, yeah. You should be agree. Yeah. For example, in a farmer, petani, farmer, yeah, with a businessman, they works very different. Yeah, there are two analog. Yeah, a farmer every day. Yeah, digging the file, mencangkul. What's the in English? Digging the file. Yeah, mencangkul apa? Yeah, that is maybe the art is not exercise similar with similar, but that is the working every day. But in the businessman, banker for example, yeah, maybe the work type of work is very different. Yeah, so that is a make of the different responses of the exposure of the, for example, and the rich of food of lipid, yeah, the rich foods of free radical, yeah, smoking cigarette, yeah, for example. Now, that for that is the difficult in Indonesian people to identify, yeah, by the personal medicine. I'm sorry, by the population. If we make evidence, yeah, that is difficult, yeah, to find of evidence in guideline, yeah, to use, for example, anti-hypertension, to use, for example, anti-aggregation for stroke, yeah, one individual that is good respond by aspirin, but another, yeah, good respond with clopidogrel. Someone respond by amlodipine, but then another only with, for example, valsartan. Nah, that's so in Indonesian, a very the ideal, yeah, to apply of precision medicine. So the problem that's, yeah, that is very cheap or expensive. Very cheap or expensive? Very expensive. But of the health insurance, yeah, yeah, it's not covered for all of the high examined laboratory examination, for example, to identify of gene. That is problem. Okay, you know? So that our mention can to answer in the second question. Okay, you satisfied? Okay, thank you. Yeah. Oh yeah. Oh yes, yes, yes. That is in another setting. What about the pharmacies? Yeah, what about the pharmacies? Basic approach of pharmacies, yeah, until now, it population. All of the study, yeah, in the pharmacies, that is make of the population. So for that, for next, basic of the study is individual, yeah. There are many pioneers of to individual research. Yeah, for example, one of the pharmacists. Yeah, we as a member of that study. Yeah, it is with personal medicine to develop of stroke anti-aggregation. Maybe for next, yeah. Okay, thank you.
Yes, thank you for Ismail. And in addition to that, so we know that some patients with stroke come with recurrent stroke. They use clopidogrel in everyday life, but unfortunately, there is actually examinations, genetic testing, Sp.2C19, that was actually covered by ASCAS. But now it's not covered by our national insurance. This is genes examinations may reveal patients who actually has an intolerance with, or is not responsive to the clopidogrel. Since actually, if it can be done in the great population, so we can choose which one can consume the clopidogrel and which one is not to prevent recurrent stroke. That's one of the examples in clinical setting. But I think the questions is also needs to be given to another speakers, Prof, because I want to know the conditions in different countries, such as in Taiwan and the UK. So the same questions according to the feasibility of the screening, genetic testings for preventions in UK and in Taiwan. What do you think about that, Professor Delvac and Dr. Wen-Hai Chou?
Yeah. Okay. Thank you very much. So I think the answer is that it's already been applied. For example, in the UK, some of the treatment is based on principle of personalized medicine, but it's only the minority, not many, and it's depend on the cost benefits of the approach. But in the future, it may change. So, for example, so here in the UK, most of the health cost is covered by the government through the National Health Service. So basically, it's free service, and they need to make sure that everything is cost effective. And for example, the most probably obvious practice of personalized medicine is in the treatment of breast cancer. So one of the recommended or used treatment is Herceptin, trastuzumab. But of course, if the cancer is triple negative, don't have the HER receptor, it's not going to be effective. And the cost of the Herceptin and compared to doing the screening of the triple negative, all the genes of the three receptors is a lot more expensive of the drug. So it's a routinely used. People's got the screening, genetic screening, and if it is fulfill the criteria, they will get the chemotherapy, the Herceptin. And there's a lot of other treatment as well. And genetic testing now getting cheaper and cheaper. Even in the future, we will have whole genome sequencing less than probably 100 pounds sterling or something. And in the UK, we started the sequencing, whole genome sequencing for 5 million people already started, and it's already past 1 million now. So here they will have the complete data of the population genome, and that will make in the future the prospect of practicing precision and personalized medicines become like public health practice. It's not no longer personalized again. If we can have the whole genome sequence data from the population, then the practice of personalized medicine can be applied in the public or public health setting. So that's what my prediction. What happened in Indonesia, I don't know. And it's depend in the situation. The cost benefits needs to be considered. So I've been involved in a study in East Java in Malang, and we try to do some population-based approach to reduce the cardiovascular risk, in particular high blood pressure, because we found that 30% of the individuals in Kabupaten Malang got high blood pressure. And we don't do precision medicine, we just ask them to consume either ACE inhibitor or calcium blocker. So without knowing that, that's cheaper. But the result is that after 1 year, 30% of high-risk individuals become non-high risk. What about the other 70%? Maybe need different drugs and so on. But the situation's not allowing us to choose the precise medicine for each person, because this is a community therapy. So, and that's probably a different situation. So it's probably the bottom line is that we are moving to that direction in the future with the more knowledge in the genome function and so on, and the affordable genetic testing, and the more sophisticated therapeutical approach, then we can choose which therapy that best for these people or not. Thank you very much.
Yes, thank you, Prof. Delvac, for the very outstanding explanations about this. So it is opening our eyes that really precision medicines will be the future rather than taking one size fits all. Okay, so the same questions would like to ask to Dr. Wen-Hai Chou. How about the screenings of or genetic testing or application of precision medicines in prevention stage in Taiwan? Would you like to give us any experience or maybe some explanation what happened in Taiwan?
Okay. So I was trained in US, and then I moved back to Taiwan about 6-7 years ago. And then the health insurance in Taiwan is amazing. So you can see doctor, physician, often. And then, but in the US, you have to wait. And but in terms of precision medicine in stroke, I'm not a physician myself. So by talking with a neurologist, I don't think precision medicine is currently available in Taiwan yet. But I know that there's one study recently that talk about the NOT3 mutation. The NOT3 mutation that is often found in Asia, and it will cause small blood vessel in the brain. And so this patient has the mutation, will have, I think, called Momo disease. So that's the only thing that I know of. Okay, thank you.
Yes, thank you very much for the sharing, Dr. Wen-Hai Chou. So next, because time is running, is there any questions from the attendants? One more question, please.
Hi, my name is Amin. I'm from Malaysia. I wanted to ask to the third speaker. So RNA therapy is challenging because RNA is in nature is really easy to denature outside of the cells. So I wanted to know currently what are the most common delivery methods for use in clinical settings and also in research settings. And my second question is that how do you use RNA therapy to approach specific tissues and also for tissues that are in a suspension-like state, like for cases in leukemia and etc. Thank you.
Okay, thank you for the question. So, Prof. Delvac, you may directly answer the questions.
Yes. Thank you very much for the question. Number one, how to make RNA more stable and how to deliver it. So we use modified RNA. So the RNA is not the same as the natural RNA that produced in human or in mammalian. So there are several nucleotides that need to be modified. And then that's can be done quite easily now in the lab. So that's very common method. So the most often cause of RNA degradation, of course, the RNAs, the enzyme that can degrade RNA, and also immune response, because the body, mammalian body will recognize it as a foreign materials. But then if we modified some of the base, for example, the uridine changed to pseudo-uridine, that's the most significant changes that we can make. Then we can increase the stability quite significantly. And that's the one that used by common messenger RNA therapy, including messenger RNA vaccine at the moment. Then, of course, after that, delivery mainly use lipid nanoparticle, the LNP. There's a lot of variation from the standard one to the most sophisticated one. Of course, if you move from laboratory-based research to industry, there is different. So the one that we use in the lab, we just use the common lipid nanoparticle that available in the market. But if you ask me what's the Pfizer vaccine use, I don't know. They have different kind of recipe that make the the delivery is better and cheaper for production. But the principle is the lipid that coating the RNA, and that will help the RNA to pass the membrane, the phospholipid membrane. Then the second question, how to target specific cells or specific organs? Is that right? Is that the question?
Yes.
Okay, so this is challenging because if we want to target to specific organ, what we can do is to inject locally. For example, if we want to target heart cells, we just inject it in the heart. But whether it is feasible for routine therapy, then it is very difficult. Now, there is one development and it's not in the molecular biology area, but more in the material science, the nanoparticle development, nanomaterials. People research that to find out some substance, nanosubstance that can bind to specific receptor in specific cells, so that we can hopefully can direct the RNA to a specific cells. So I think there is once already been developed for liver cells, hepatocytes delivery, but I'm not quite sure whether cardiomyocytes and neuronal cell and so on probably is not developed yet. But for liver, there is one nanoparticle that can bind to specific receptor in hepatocytes, and that will improve or increase the cell specificity of the nanoparticle. So the technology is developing, and I will not be surprised if in the next few years there will be specific target or specific technology that can target RNA or DNA to a specific cells. And there are another approach as well, apart from the nanoparticle development, is using the microsome. So microsome is like a vesicle that can be produced in cells, and then we can produce microsome and then load the RNA, and then we can add some protein, specific protein in the microsome. When producing the microsome, we can add something so that the protein can only bind to specific receptor in our target cells. So that's microsome technology. So there are two main things in the future in the development of cell-specific target of RNA or DNA therapy. One is development of nanoparticle, nanomaterials, and second is microsomes. Okay, I hope this will answer your question. Thank you.
Yes, thank you, Prof. Delvac. Okay, so is there any questions? The last questions for this panel discussion? No? We still have 6 minutes left? No questions? Yeah, okay then. Thank you. Thank you very much for attending today's. Give applause to our 3 outstanding speakers, Prof. Ismail, Dr. Wen-Hai, Chou, and Professor Delvac. Hopefully we can join another meeting about precision medicine, especially in neurology case, because we need that. We need that improvement in our social guideline, health guideline, to be more personalized and more precise. So to sum up, wide range and effectiveness of treatment, especially in stroke or neurovascular disease, make us realize that there is a need to do more effort in precision medicines to improve patient outcome. So based on our discussions today also, that there are some potential biomarkers that can be used in the future as a precision medicine and specific treatment in stroke patients, and also the cardiovascular patient that has been mentioned by the third speaker. So thank you very much for your attentions. I'm finishing this last panel. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Dr. Vega, and also Prof. Ismail, and also thank you for Dr. Wen-Hai Chou from Taiwan, and also Prof. Delvac Oceandy. Terima kasih Bapak sudah berkenan bergabung di Tunggu Kedatangan di Indonesia. Monggo bisa foto dahulu. So let's take a photo together for Wen-Hai Chou and Prof. Delvac. Please turn on your camera. So for the photo session. Yeah. Okay, so thank you so much. And guys, and that was the 5 panel for Summer Course 2023. So once again, I would like to repeat my information regarding for tomorrow agenda. First thing first, tomorrow we will go and we will go to the Puskesmas at 8. So make sure you already at the lobby 7:15 or 7:30, right? Bring all your belongings, especially for overseas students, right? Because at 8 we have to go to the Puskesmas. And for UGM students, you will go to the Puskesmas. There is 2 options. You can ride by your own vehicle or you can join with us by bus. Okay, and for the overseas students, you will stay at the dorms in the Puskesmas area. And don't forget to finish your essay until November 26th. Once again, you can finish your essay until November 26th at 11 p.m. Indonesian time. Okay, so thank you so much for coming and see you tomorrow and bye-bye everyone.